Hello and welcome once again to APHA's 15 on COVID-19 series. I'm your host, Dan Zlott, Vice President of Education here at APHA, and today we're going to be talking about updates on Remdesivir. Certainly a lot of developments over the weekend. It's been all over the news constantly, and so let's see what all the fuss and excitement is about. Let's go ahead and jump in. As usual, I have nothing to disclose. Here are your learning objectives for today. All right. Well, so why has there been so much excitement about Remdesivir, really starting since Friday and running all the way through the weekend? The reason is that there have been two randomized placebo-controlled trials with published results, sort of. And you'll see what I mean when I say sort of as we get to the end of today's episode. So that's what's generating all the excitement and all the talk on the news and really everywhere else you look. But of course, as with everything in COVID-19, it couldn't be simple and straightforward. The results of these two trials couldn't be more different. They're completely contradictory. And so it's, I guess, par for the course for this. Nothing has been easy for us as clinicians, and we're trying to figure everything out as we go. And to have two trials with such, stark differences in results is interesting, to say the least. So without further ado, let's go ahead and dive right in and take a look at our first trial. So our first trial is a trial that's coming out of China. It's a multi-center randomized double-blind placebo-controlled trial in 237 patients with severe COVID-19. Randomization was done in a 2-to-1 fashion, 2 patients into the Remdesivir arm for every 1 patient in the placebo arm. That's pretty standard in a situation like this where patients actively are seeking therapy. They're more likely to participate in a trial if they think their odds of being placed into the active drug is better. So nothing wrong with that, very common practice. The groups were stratified according to the level of respiratory support that was required, either no O2 support or support via nasal cannula or face mask. That was one strata. And then the next one was for patients who required more intensive oxygen therapy. So that's oxygen support via high flow nasal cannula or non-invasive or invasive mechanical ventilation, or in the most extreme case, ECMO, extracorporeal membrane oxygenation. So stratification is just a way to ensure that when you're done with a trial, there's an equal number of patients with each of those groups in each of your arms of your study. So again, nothing wrong with that. Very common trial design. And given what we know about COVID-19, that makes a lot of sense. So no problem with that in terms of study design. The intervention that was tested is pretty much what we've seen for Remdesivir so far. 200 milligrams IV on day 1, followed by 100 milligrams IV daily thereafter on days 2 through 10, so a total of 10 days of therapy, or matched placebo. So again, keep in mind this was a double-blind placebo-controlled trial. So who are the patients in this study? The patients had to be at least 18 years old or older. They had to have be confirmed COVID-19 positive by PCR. They had to have evidence of pneumonia on chest imaging, and the authors didn't specify whether that was chest X-ray or chest CT, so we're not entirely sure, but some evidence of pneumonia via radiography of the chest. And then they had to have an O2 sat of less than or equal to 94% on room air, or have an FiO2 over arterial oxygen ratio of less than or equal to 300 millimeters mercury. Additionally, patients had to be willing to use contraception during the study period and for at least 7 days thereafter. The exclusion criteria were women who were pregnant or breastfeeding, patients with hepatic cirrhosis. Keep in mind what we know about Remdesivir. We do know it has some hepatic toxicities, and so you're going to see some liver-directed exclusion criteria. So the other one is AST/ALT greater than 5 times the upper limit of normal. Patients with severe renal impairment, and they define that as an eGFR less than 30 mils per minute per 1.73 meters squared, or anybody who is on any form of dialysis, whether that was CVVH, continuous renal replacement therapy, intermittent hemodialysis, peritoneal dialysis. Any form of dialysis was an exclusion criteria. If there was the possibility that the patient would be transferred to a non-study hospital within 72 hours, and if the patient had received any investigational therapy for COVID-19 within 30 days prior to screening. Now, it's important to keep in mind, because this study took place in China, they do not consider lopinavir, ritonavir, interferon therapy, or corticosteroids to be experimental, and therefore those are not considered exclusion criteria. In other words, all of those drugs, lopinavir, ritonavir, interferon, and corticosteroids, were allowed for patients on study. So one potential confounding factor there, mostly for the lopinavir, ritonavir, and the interferon. And we'll touch on that as we get into some of the study limitations. So what were the endpoints of the study? The primary endpoint was the time to clinical improvement within 28 days of randomization. So they're looking at really clinical improvement, and they have a specific way of measuring that. That was defined as either discharge from the hospital or a 2-point improvement from baseline on clinical status. And the way they scored that is as follows. So death is 6 points. If you were admitted to the hospital and you're on ECMO or mechanical ventilation, you get 5 points. If you're admitted to the hospital and you require non-invasive mechanical ventilation, or you're on high-flow oxygen therapy via nasal cannula, that's 4 points. If you're admitted to the hospital and you require O2 therapy via nasal cannula or face mask, that's 3 points. If you're admitted to the hospital and you don't require oxygen therapy, that's 2 points. And finally, if you're discharged, that's 1 point. So what they're looking at is a decrease of 2 points. So for example, if you were admitted and on ECMO, and then at the time at 28 days, you were admitted and didn't require any oxygen therapy, that would be going from 5 points down to 2 points. So that's more than a 2-point improvement in your score, and therefore that would be considered clinical improvement. So that's kind of how the scale works. Now moving on to the secondary endpoints. The first secondary endpoint was the proportion of patients in each category on that 6-point scale we just talked about at day 7, 14, and 28 after randomization. So they wanted to see kind of how patients' status progressed over the course of the 28-day period after randomization. They are also looking at all-cause mortality at day 28, the frequency of invasive mechanical ventilation, the duration of oxygen therapy, the length of stay, and the last secondary endpoint was the proportion of patients with nosocomial infection. All right, so as we start to examine the results of the study, let's start off by taking a look at the patients who made it into the study. There were 237 patients in the study, 158 patients in the remdesivir arm, and 79 patients in the placebo arm. And keep in mind, this was a 2-to-1 randomization, so that's exactly what you would expect. The median age was about 65 years old. Based on the rest of the COVID-19 literature, this is about what we would expect. Nothing unusual at all there. There was a slight predilection for male, so 59% of the patients in this study were male. And again, that fits very much with what we know about COVID-19, especially when you start to look at moderate to severe COVID-19 disease. More of those patients tend to be male. So again, nothing at all unusual there. 82 to 83% of patients had a clinical score of 3 at baseline, and keep in mind the clinical score of 3 equals patients who were admitted to the hospital and required oxygen therapy via nasal cannula or face mask, but did not require any form of mechanical ventilation, whether that was invasive or non-invasive. Now, it turns out that there were some discrepancies between our groups, so let's talk about those. There were more patients in the remdesivir arm who had comorbidities than there were in the placebo arm. And in particular, there were more patients in the remdesivir arm who had hypertension, diabetes, or coronary artery disease. So we know that those are significant risk factors for both morbidity and mortality in COVID-19. So that imbalance would tend to favor the placebo arm. Additionally, there were more patients in the remdesivir arm who had a respiratory rate of greater than 24 breaths per minute at baseline. So that would tend to suggest that those were patients who were maybe a little bit more sick. There was something going on in their lungs and they required a higher respiratory rate to maintain their status in terms of oxygenation. So that likely favors placebo. We don't know for sure, but with a little bit of guesswork, we would tend to think that that would favor the placebo arm. And likewise, there were more patients in the placebo arm who had been symptomatic for 10 days or less at the time of therapy initiation. And so again, this is an extrapolation to be clear, but with antiviral therapy, we tend to think that the more quickly you can initiate therapy, the more effective the therapy is. And so that would seem to favor the placebo arm as well. So we have 3 imbalances, all of which sort of tilt in the favor of the placebo arm. And so that's going to make it difficult for us to really assess the results of this trial. Just a little bit of a spoiler there. So some of the other results, the main finding here was that there was no significant difference in median time to clinical improvement between the remdesivir group and the placebo group, and the number there was 21 days in the remdesivir group versus 23 days in the placebo group. And the image there is sort of a reverse Kaplan-Meier curve demonstrating the cumulative improvement over time. The remdesivir is shown in red and the control arm is shown in blue, and you can see those lines fairly well overlap. There's really not a lot of separation there. And so when we run the statistical analysis on it, the hazard ratio was 1.23 and the 95% confidence interval was 0.87 to 1.75. And because we're talking about hazard ratios, since that 95% confidence interval crosses 1, that is not a statistically significant outcome. So no benefit there. Additionally, there was no significant difference in the 28-day mortality rates. So it was 14% in the remdesivir group as compared to 13% in the placebo group. There was also no significant difference in clinical improvement rates at 14 and 28 days between the two groups. So no improvement no matter what subset or what endpoint we're looking at here. The 14-day different rate was 27% in remdesivir group and 23% in the placebo group. And the 28-day rate of improvement was 65% in the remdesivir group and 58% in the placebo group. So no significant difference there. Some additional outcomes that were looked at. There was no significant difference in the duration of mechanical ventilation either. And the average here was 7 days for remdesivir versus 15.5 days for the placebo group. Now that might seem to be a large spread. However, there was a relatively small number of patients who required mechanical ventilation over the course of the study. So even though that spread seems significant, it was not statistically significant when they did the analysis. So the difference, so they calculated the average difference was 4 days shorter for remdesivir, and the 95% confidence interval was -14 to 2. So this is a little bit confusing. We're not talking about hazard ratios here. We're talking about the absolute difference. And so since the 95% confidence interval crosses 0, this is not statistically significant. There was also no significant difference in the length of O2 support required between the remdesivir and placebo arms. 19 days of oxygen support required in the remdesivir arm as compared to 21 days of oxygen support in the placebo arm. And there was no significant difference in length of hospital stay. So in the remdesivir arm, the average length of hospital stay was 25 days as compared to 24 days in placebo. And so now we'll move on and talk about some of the safety updates. So adverse events were reported in 66% of remdesivir patients as compared to 64% of placebo patients. So when you see numbers like that, that tells you the therapy is relatively well tolerated unless you see a significant signal. So if there's one particular adverse event that pops up for the remdesivir but doesn't show up for the placebo, that might be a safety signal. So let's take a look at what the specifics were. The most common adverse events in the remdesivir patients included constipation, hypoalbuminemia, hypokalemia, anemia, thrombocytopenia, and increased total bilirubin. So the only one of those that sort of raises a red flag based on what we know about remdesivir so far would be the increased total bilirubin. So now let's take a look at the same information for the placebo group and see if there's any signal there. So the most common adverse events in the placebo patients were hypoalbuminemia, constipation, anemia, hypokalemia, increased AST, increased lipids, and increased total bilirubin. So that's kind of interesting. Traditionally, we would think of the hepatic adverse events to be associated with remdesivir just based on what we know of remdesivir from previous clinical trial experiences, both in Ebola and in some of the COVID-19 experiences. But here we really don't see a lot of difference in the adverse events between placebo and remdesivir. So that's interesting to say the least. Some additional safety outcomes. Severe adverse events were reported in 18% of remdesivir patients as compared to 25% of placebo patients. The most common serious adverse events in remdesivir patients were respiratory failure or acute respiratory distress syndrome, cardiopulmonary failure. And when it comes to the severe adverse events in the placebo patients, they were exactly the same, and the rates were slightly different. So that's sort of interesting. It's difficult to suggest that those severe adverse events are actually a complication of the drug therapy as compared to just something in the natural history of COVID-19 disease as it progresses. So I wouldn't make too much of that at this point. It turns out that there were more patients who discontinued remdesivir than there were placebo, and it was 12% of patients who discontinued remdesivir as compared to 5% of patients who discontinued remdesivir. And the causes were really interesting. So the most common reason for discontinuation in remdesivir was respiratory failure or acute respiratory distress syndrome. That's a little bit odd given what we know about COVID-19 disease. Unless you really thought that the respiratory failure or the acute respiratory distress syndrome was caused by the remdesivir, it's strange to me to discontinue that particular medication, given that that's what we're trying to treat and prevent. So, I certainly wasn't there. I wasn't involved in the discussion, so I don't have any firsthand knowledge of that, but it does seem like an odd reason to discontinue therapy. And in the placebo arm, the most common reason to discontinue therapy was secondary infection. All right, now that we've gone over our first trial, let's talk about some of the limitations of the study. The first limitation is that patients were treated with other antiviral therapies. So this has continually been an issue with a lot of the data coming out of China. They sort of threw the kitchen sink at these folks and then didn't consider that to be investigational. That's just part of standard of care. And so that definitely confounds our ability to really assess the impact of remdesivir. Now that said, the proportion of patients who received some of these therapies was relatively equal across both groups, so at least it should be controlled for. So that's one plus, I guess, to this particular trial design. The other big limitation of the study were the imbalance in the baseline demographics. And keep in mind, those all tended to favor the placebo arm. So that really makes it difficult to fully and accurately assess the outcomes that they reported. With that much bias towards the placebo arm, it's quite possible that that may have overcome any potential benefit that we would have seen. We just don't know, and that's one of the knocks on this trial. It was relatively well designed, don't get me wrong. I mean, it's the gold standard that we always look for in terms of randomized double-blind placebo-controlled trials. It just happened to be that the demographics weren't as even as we would have liked at baseline. And then the other interesting thing, again, were the unusual reasons given for discontinuing remdesivir. As I said, it's difficult for me to understand the thought process there, given that that's what we were attempting to treat with the remdesivir, and given what we know that that's part of the natural history of COVID-19 as it moves into the moderate to severe COVID-19 stages. So other than that, really not a lot of knocks you can make against the study. It really was relatively well designed. All right, now let's go ahead and move on to our next study. So this study is a multi-center randomized double-blind placebo-controlled trial in more than 1,000 patients. And this study was conducted in part by NIAID, so it was overseen or coordinated by NIAID, the National Institute for Allergy and Infectious Disease, out of the National Institutes of Health. And so we don't really have full data here. All we really have is a news report. So that's what we're working off of. And so do bear that in mind. Who are the patients? These were hospitalized patients with advanced COVID-19 disease and lung involvement. We don't have any more specific information there. So remember, on the last trial, we had very specific O2 requirements, FiO2 over arterial oxygen requirements, etc. We don't have any of that here. We just know that they're hospitalized and that they have advanced COVID-19 with lung involvement. The primary endpoint was time to recovery. The secondary endpoints were mortality rate, and there are probably others as well, but we don't have the full manuscript. We just have a news report. So we're working off of that. So the way that this sort of came about, the Data and Safety Monitoring Board, or the DSMB, did an interim analysis of the results of the trial, and that's pretty common. This happens frequently with large trials. You want to make sure that there's no safety signal that would indicate a significant safety issue, or if you see either significant benefit or significant lack of benefit where it would be impossible for the study to meet its endpoint, there's no point in continuing to expose patients to an unknown investigational therapy. So that's the point of DSMB's very common practice. So they met and reviewed the available data as of April 27th, and here's what they found. Remdesivir patients had a 31% faster time to recovery compared to patients receiving placebo. And so that was 11 days versus 15 days, and that was highly statistically significant. You can see the p-value there. Additionally, there was a strong trend that suggested that remdesivir patients had a lower mortality rate compared to patients in the placebo arm. And so the mortality rate in the remdesivir arm was 8% as compared to 11.6% in the placebo arm. And that just missed being statistically significant. Again, the p-value is there for you, 0.059. And so what that suggests is that there's probably a signal there, and they just need to accrue a few more patients into the study, and they will hit statistical significance for that particular outcome. So we'll see as the full study is published. So the biggest limitation here is that the rest of the study, in terms of detailed inclusion-exclusion criteria, the safety results, the secondary outcomes, the baseline demographics comparing one group to the next, we don't have any of that. So we're just working off of very generic information at this point. And so once that becomes available, we'll revisit and give this a more thorough treatment. So with that, all right, so what's the bottom line with remdesivir? Well, first off, there are significant flaws in the study with the most robust data, or at least the most available data. So that would be the Chinese study. The study with the best results, which would be the NIAID study, has not been fully released. So we're essentially working off of a press clipping. That said, remdesivir does appear to be effective for the treatment of advanced COVID-19, assuming, and this is always a danger, assuming that the information from the news briefing from the National Institute of Allergy and Infectious Diseases bears out, and that information is accurate without major flaws in their study design. And we also know that remdesivir has now been granted an emergency use authorization for the treatment of COVID-19 by the US FDA. And so one would hope that they have access to all of that information that we don't have access to yet. It's hard to imagine that they're granting emergency use authorizations based off of press clippings. So when the rest of us have a chance to take a look at that data, hopefully we'll also be equally impressed. There's also some potentially interesting information regarding the length of remdesivir therapy that's been coming out. There's a couple of papers that I've seen come across PubMed looking at maybe a 5-day course of therapy instead of a 10-day course of therapy. So we didn't have time to get into that today. So maybe we'll take a look at that once we also have the full length, the full information from the National Institute of Allergy and Infectious Diseases study. And the last point is that, as always, until the full data set of the NIAID trial is released, I think it's fair to view those results with a bit of skepticism, or maybe more than a bit of skepticism. Until then, we're basically relying on a news release to say, yes, the results were great, believe us. And I'm never comfortable doing that. I always like to see the data myself, and then I can make up my own mind about whether they're really as good as they say they are. So that will wrap up today's 15 on COVID-19 episode. We hope that you found that useful and helpful. And with that, we are continuing to look for your suggestions. What questions are you getting from your colleagues, from your patients? Send those our way so we can help you answer them. covided@aphanet.org is the email address. And a huge thank you to all of you who have already submitted suggestions. Our upcoming topic for Friday's episode will be talking about sedation drug shortages. So we've gotten a lot of questions from hospital pharmacists looking for how to prepare for some of these shortages in the event that they see a severe spike in their particular area. So we've got some good information for you about some things to think about and how to prepare. So please join us on Friday, and we hope to see you then.